Thank you, Nagore. Yeah, so myself and Navina are going to talk about what's happening in NHS Lothian and data lock, which is the sort of eastern side of things. But the principles we want to sort of say, this can happen in any part of Scotland. It's that partnership between the NHS and research. A couple of things. By routine, what I mean by routine is things that are collected in the course of everyday practice. Not another questionnaire put in because someone's doing a research project, not a box to be ticked because a manager wants to report on such and such. It's got to be things that are genuinely helping clinical care and of benefit to the patient service user that we're working with. The other thing to say is all of my images are generated by AI Copilot, and one of my other hats is as clinical advisor to the Microsoft 365 program. So I think all that sort of AI in clinical practice, again, a huge, interesting area that I will not talk about today. I've got lots of things like that, and I don't get paid anything by anyone. What we've done since the pandemic really is a big digital transformation in Glasgow. In some ways, learning from what Nagore had led in Glasgow, we followed on with in Edinburgh. We moved on to the main health board product track in 2016. We do not have a separate mental health product in Lothian. Pros and cons to that. And then with the sort of pandemic, we kick-started a whole bunch of stuff like I'm sure you've done with video consultations. We were the early adopter site for Lothian with digital prescribing, etc., etc., etc. But what I really want to jump in with here is with Paperlight, because what we did was we found ourselves on, I'll call it an enterprise system. This is a system that can run an entire health board, which is what TrackCare is, but it wasn't configured for mental health. So we thought, right, we've got to use it and develop it there. The temptation, isn't it, with mental health data is it's all free text, and there's so much free text in there. It's not like perhaps the surgeons who can count how many swabs go in or blood pressure or something else. There's so much free text. So how do we configure a clinical record to handle mental health data? And I think the answer is semi-structured. What we don't want people to do is do what I call swamp diving, which is you dive into the free text or the progress notes or the letters, you go back until you find something written by someone who you know and trust or perhaps worked for, and then you rummage in Sky Store. And how far back do we go? How long should I spend? Staff feel quite disempowered by that. And of course, what we can't do is let's throw it all at an AI because that'll sort the problem out. There's practical issues around using AI, and chucking everything at it actually causes more problems. So what we did in Lothian was we thought we don't want to do swamp diving. We had some structure in track. So we had the National Early Warning Score, results, labs, activity. It's a hospital product. It's well linked. One of the amazing things about Lothian is basically you only have to put your password in once, which still continues to amaze me. I know many other areas have got multiple different systems going on, particularly south of the border. And also, Track had these connections to the city. It's got built-in connections to primary care, electronic document transfer. I can see the GP meds, etc., etc. But also part of that is with research and data lock and so on, as will come on. So what we've done is we've built a house. It's not rocket science. The forms we built, there's nothing special about them. Nagore's got the same forms in Glasgow, but they are bolted onto the stables. This is what it looks like. And I don't want to say too much about this, apart from this is what our track looks like. Yours might look slightly different. But the things I want to point out, top level menu for mental health. Okay, alongside, you obviously got all the hospital stuff like waiting lists, results, all that is handled within the one product. The other thing I want to do, I want to pick up on Simon's excellent question about getting the patient voice out there. Front and center, on the right-hand side, we've got service user plans, which basically is things like staying well plans, what matters to you, how distress preferences, things that are alternatives to medication that work for me. We very much wanted to put that sort of patient service user perspective front and center. And the key message is you do something on the left. In this case, it's an activity, but it could be a risk assessment or working on someone's personal history or something. And you can do everything else on the right. One of the things that staff really struggled with is, how do I find it? I've got to click here, click there. We want to present the data. We want the system to work for us so people can do everything from the one screen, and they can kind of do two things at the same time. They can write the progress note while they're updating the risk assessment, etc., etc. So we worked hard on that. Those of you who want to dig into it more, This is a presentation we did at the Digital Health and Care Fest last year. And that QR code, I'll leave that up for as long as possible, is basically one of their learning toolboxes. You can dive in. We've got a little video tool, sitemap, etc. You can jump into that. And I've got that QR code on my phone later if you find me over coffee. We rolled this out during 2024, basically. So we started with CAMS in the new year, psychology, and then we have just completed the rollout. Now, one of the slight problems, as Dame Anna was mentioning, is no one's got any money. So I no longer have a digital hat in NHS Lothian. I've got one session for trying to really land this in adult mental health, but a lot of these things came to an end. So we have rolled it out and teams are now using it. And what we're trying to do is work within existing resources to make sure this is landed and embedded as well as we want to. But we are talking fairly significant numbers. So we've got 160,000 users of mental health questionnaires in Lothian. There's the big ticket items like risk assessment, structured ward round core assessment, the CAMS forms being really well used. Some of them are really just beginning to come online, but it's personal history, social history, mental state examination. And lots of these things, they're semi-structured. So there's a text box, couple of drop downs, that sort of thing. But the numbers are quite significant. So what we're doing, and Avina will talk a little bit more about this, is where does this go into a data lock environment? And when we're thinking about data, particularly with routine collected data, I want to introduce you to these 4 stages. There is lots of data. People are continually doing this and putting stuff in. One of the frustrations they get is what comes back to me. You know, it's like the Aesop's fable, isn't it? All of the footprints lead into the lion's cave and nothing comes out, and you're feeding the beast. So what does come out? Could the information be laid out better? This is a snapshot of our Tableau dashboards in Lothian. I have access to 394 Tableau dashboards with all kinds of pretty graphs on them. Now, I've got 2 problems with this. First of all, that's not available to every clinician. And secondly, mental health data is excluded from a lot of them for reasons that have perverse incentives, like the A12 waiting times for psychological therapies, means that none of the rest of the mental health times waiting data goes into our waiting times dashboards. So I think we want all of this stuff laid out better. We want data analysis, not here's the data dump. We want those analysts really working for us. Also, intelligence. Does it trigger actions? Is this live in near real time? And I really liked what Amanda was saying about this product that the patients were using to sort of put data in Singapore, and things that are coming from the main electronic record or from the patient must drive decisions. It must flag people who are becoming sick. We must be able to look at it and think, right, I've got all this data. What's it telling me today? It can't just go off and fund some research paper that's going to give us benefits in 10 years' time. It's got to land today. And then the last bit, knowledge, is it used for planning? What we want is we want to use this data for service development. We don't want service development to be based on political whim or whichever manager is speaking loudest. We want it to be based on data. And then we can actually evidence what we're doing and measure change as well. This is a product called MAST, which is used in some areas south of the border. It's basically a community mental health team waiting tool. But the point is, it's an algorithm. It draws from many data sources to show you what's hot, effectively. So what is an ideal clinical research partnership? That's one of the things we're thinking about today. I think one of the key things, I want to see this sort of two-way discussion between researchers and clinicians. Sometimes you've got the NHS over here and the academics over here, and there's one-way data flow. Either data goes into research or data comes, benefits come from research, perhaps through innovation, but they come back the other way. What I want is an ongoing daily dialogue. We're trying to get data on the outcomes of people with perinatal difficulties, for example. Let's have that. You got this great perinatal form, right? We'll use that data. Oh, it's only being filled in on 20% of patients. Can we sort of improve that? How can we present it to you to help you run a perinatal service? We want this sort of live discussion going on with routinely collected data. Real-time benefits for patients. One of the things that our executive medical director is quite keen on is if data is to leave the NHS environment, albeit anonymised, et cetera, it's got to deliver real-time benefits for Lothian patients, not general benefits. We improve research in Scotland and perhaps we have a product later. We want it to help the citizens of Lothian now, because ultimately it's their data. And also this idea that big data can tell you a lot of stuff. There's huge, big biobanks, data sets out there that you probably know more about than me, but they will only get you so far. They will perhaps help you identify a question or a pattern, and you then need to dive into the local richness, which is going to be dirty, it's going to be grubby, the data quality is going to be questionable and need some work. But you get the questions from big data, and then you perhaps find the answers from local data, and you've got that partnership there. So next steps, we need to have researchers who know the local system. We're very blessed with a number of clinical academics in Lothian who do use our system. Are they as in touch with it as I would like? Possibly not, but you know, there are certainly some people like Donald. Donald uses this every week on his ward round. He knows what's on there, and I think, you know, having those sort of interactions is really important. Data obtained via Datalock, absolutely key for this to go through a trusted research environment. Two reasons for that. One, that's the setup that we've got and we need to make the use of it. But secondly, because so much of this is free text, it's very, very difficult to redact that, particularly at scale, particularly in near real time. So actually handling that, and if data is to be consumed onward, it's through Datalock. So, and certainly Tracy Gillis, our executive medical director, is very keen that free text data will only be exported from Lothian through Datalock, because it needs to be handled in a very particular way. And also, I talked a bit about the research results in local benefits. And also, I think that gives longevity to the research. It stops our research being sort of hit and run, you know, or once and then you come back. If you've got an ongoing research development between, I was chatting to one of our non-executive directors yesterday about, you know, and I was really pleased about, you know, those links between the NHS and the universities. There's a number of universities that really get that embedded rather than effectively separate a lot of the time. So we want ongoing real-time input brings longevity. So any questions? This is not an offer for you to ask questions. What I'm saying is any research questions that might be able to make use of this. And what we're after is questions that can't be answered from existing data sources like big data sets and things like that, can be answered from routine collected clinical data, especially free text. And what I mean by that is stuff that is entered in the day-to-day clinical care, and also it comes with funding for data extraction. These are projects that the NHS is not able to, you know, we need to buy a bit of Datalock, basically, as I've been going to talk about in the near future to get some of this out. Donald's trying to get a few free searches a year, aren't you? But, you know, I think ultimately the data does need to be bought and consumed some way. That's my email. I think that is the QR code for the learning toolkit I shared earlier. And one final slide. If you want to get up to speed with digital health, what Nagora and myself have been doing over the past few years, this is a new book from the Royal College of Psychiatrists that came out earlier this year, edited by myself and a couple of colleagues south of the border, one at South London and Maudsley, and one in the north of England, covering anything, anywhere to do with digital mental health. It's a sort of beginner's guide for your average clinician. Thank you very much.